Welcome everyone to this evening's event, Bridging Science and Care, Tissue Engineering and Healthcare, a conversation with Dr. Katie Hixon, sponsored by the Center for Ethics and Society at St. Anselm College. I'm Mark Regani, the interim director of the center, and tonight's conversation is the first of what we hope will be many public dialogues and opportunities to learn on emerging concerns for ethics in our world. As a member of the Army BioFab USA ecosystem, we are really interested in engaging one of these emerging innovation hubs that really looks at some of the newest technology, some of the newest opportunities and challenges in medicine and science research. The Center for Ethics and Society has a mission to enrich knowledge and practice of principled ethical decision-making by addressing important social, organizational issues through collaborative discussion, research, and education. Our vision is a flourishing New Hampshire in which organizations and communities work together for the common good. It's our hope that you who are present here tonight, one, have the opportunity to grow your knowledge in this fascinating area of cutting-edge biomedical research right here in our state, that you thoughtfully consider the ethical implications for our communities and the wider world. And three, that you share the fruits of this presentation and the following conversation with others. We believe in transformation through dialogue, and collaborative discussion is at the heart of civil discourse and responsible citizenship that our states, our country, and our world so desperately need today. Before getting underway, I'd like to extend particular thanks to Ms. Hannah Degnan, our Assistant Director for Programming, without whom this event could not have gotten off the ground. Our center interns, Giles Bean and Natalie Marker, for their logistical help. Dr. Sarah Glenn, our faculty consultant for bioethics initiatives at the Center for Ethics and Society, and the Spotlight Crew for being our gracious hosts. Now to our honored guest for this evening. Dr. Katie Hixon is an accomplished researcher and educator at Dartmouth Engineering, where she serves both as an assistant professor of engineering and a clinical assistant professor of orthopedics. She's the principal investigator at the Hixon Lab, which is focused on developing innovative treatments to support healing in patients where tissue repair is challenging, particularly large and complex injuries from disease or traumatic injury. With a focus on developing innovative therapies, such as using manuka honey, which has natural antibacterial properties, Dr. Hixon's research utilizes orthopedic and craniofacial models to drive breakthroughs in musculoskeletal health. Her work seeks to enhance healing processes and improve the quality of life for patients facing these complex challenges. Through her commitment to interdisciplinary collaboration and cutting-edge research, Dr. Hixon is making significant contributions to the field of engineering and orthopedics. So if we could all join together and welcome our esteemed guest tonight, Dr. Hixon.
Good evening. Thank you for having me. I really appreciate the invitation to come and talk to everyone about this. So I like to just start out, always start my classes like this too, just giving me kind of my background and why I'm here. So I'm actually from Iowa originally, which is nowhere near New Hampshire. I was born and raised in Iowa. I went to the University of Iowa for my undergrad, and I went to my graduate school in St. Louis. At St. Louis University, which is a small Jesuit school, and then I did my postdoc at WashU. In all of these areas, I actually focused on biomedical engineering. So biomedical engineering was my major in my undergrad, my graduate degree, and then my postdoc I did in a biomedical engineering lab that was focused on orthopedic surgery. So all of that together, when I first started in my undergrad, I was really, really excited about biomedical engineering. And I did a bunch of research and I found a field called tissue engineering. And so tissue engineering is really not very old. There's always a laugh when I'm teaching my students at this point because I tell them it's from the late 80s and they feel like that's very old, but compared to biology and chemistry and kind of the original sciences, tissue engineering is a very new field. It was not really defined until I said the late 80s. It's really this interdisciplinary field that's going to pull together engineering and sciences, and brings them together to maintain, restore, or improve the function of tissues and organs. And so there's a lot of ways that you can use this. So when I first got interested in tissue engineering, I did tissue engineering research in my undergrad, PhD in tissue engineering, and then here I am now. So I wanted to start by explaining really how we use tissue engineering and why it's important. So tissue engineering as a field, the goal of it is to create these off-the-shelf substitutes. And what I mean by off-the-shelf substitutes is something that is stored in a hospital that a physician, surgeon can just take off the shelf and implant into a person. So it's basically ready to go, it's sterile, it's the right size, etc. And so this goal of tissue engineering has been focused on basically every tissue in your body that you can think of. So everything from your skin to your kidneys, your liver, your bone, even your brain. Folks have done tissue engineering research in this. So my group does primarily focus on musculoskeletal tissue, so muscle and bone, a little bit of skin and tendon. But tissue engineering as a field has really expanded, and you can find all these tissues being worked on within this field, which is very exciting. So before I explain more about how we use tissue engineering, I want you to remember a couple things. So tissue engineering, we call it the field that has kind of three big parts of it. So the one I really want you to take away from this today that I'm going to talk about the most is our scaffold. Our scaffold is our three-dimensional structure that's really being supporting tissue growth. So if you think about it, you have a large defect in, for instance, your bone, we have to put something there to help the bone heal. That's what our scaffold is going to do. It's a three-dimensional structure made of some type of material, typically a natural polymer. So thinking about, collagen. Collagen is a material that's very prevalent in your body. We use collagen to make a scaffold. There's a lot of different types of scaffolds, which I'll talk about in a bit, but basically we create this three-dimensional structure to support the new tissue. It's very similar to if you were to use scaffolding if you were building a new building. Right? So if you are putting together a brand new house, you have scaffolding on the outside of the building to support the building while you're putting on the walls and the windows, all of those pieces. And then eventually, as the house comes together, you take the scaffolding away. So it's very similar in tissue engineering in that our scaffold is not permanent. So we implant it, and then over time, as the body is replacing the scaffold in the tissue, it breaks down and goes away. So it's excreted through urine, etc., with no bad byproducts. So it's similar to something like a hip implant, that you implant something that's helpful in healing. But the idea is that your body replaces it with new healthy tissue, and then the scaffold is going to degrade or break down over time. So different in that sense. We also can add cells to this. So the cells are, of course, the big players in tissue engineering. They're the ones that are doing all of the new tissue growth, tissue healing, right? There's so many different types of cells in your body. There's cells that help, make the new tissue. There's immune cells. There's cells that make blood vessels, but those are the big players with the scaffolds. So the scaffolds will often tell the cells what they're supposed to be doing. And then our bioactive factors, which I'm not going to really touch on today, but these are basically our signals that tell the cells what they're supposed to be doing with the scaffold. So we always say these are kind of our three pillars of tissue engineering: the cells, scaffold, and the factors. And I'm very biased because my group focuses on scaffolding, but I think that scaffolding is the most important because it provides the three-dimensional structure, and it's the part that we really have to change or modify as we move through different types of tissues. Okay. So that being said, there are so many ways we can make different types of scaffolds, which is really important, right? So thinking about your body, if I were to ask you to make something that looks like skin and make something that looks like bone, they look very different, right? Your skin is thin and flexible. It's protecting your body. It has really great kind of water retention properties. Whereas your bone, right, is three-dimensional. It can take loading, so it's much stronger. It's actually mineralized. It has these minerals through it, which is why it can take this loading. And so because they're so different, we have to be able to design our scaffolds to be different. So there's so many ways we can do this. And although this is a bit of an overwhelming figure, but many of these you've heard of. So 3D printing is something that has become very big in the last decade. 3D printing allows us to, in a couple of different ways, essentially print something that's three-dimensional structure that's made of some sort of material. So 3D printing is something that can be used to make a scaffold. Another really common one is a hydrogel. So a hydrogel is essentially like Jello in your kitchen. You have, your powder, your polymer, you add a liquid to it, it gels together, and you have kind of this three-dimensional gelatinous gel, basically. That is what it is. So that's also a way that you can make scaffolds. And so hydrogels are really, really squishy. They're like 99% water. They're really great for storing cells, storing drugs, and delivering them to a tissue. We can also take that and we can freeze it. When we freeze it, all the water in that gel will actually expand into ice crystals. And when they melt out, they get this very interconnected macroporous structure. So again, we have all these different ways of making these scaffolds. And so what our group does is we really focus on using all of these different types of tools towards a different type of tissue. And so we really have to think about, what does a tissue look like naturally when it's healthy, and how can we imitate that in a biomaterial scaffold way such that the body will be able to heal from that. Okay, so our kind of focus is to promote tissue regeneration. So again, this is something we're implanting into a person ideally, that over time the healthy tissue is going to be made into that scaffold, make new tissue, and then the scaffold itself will break down. And then we typically focus on bone, skin, muscle, tendon, etc. I've already shown you a couple different ways to make scaffolds. So now what I want to do is actually show you some specific examples of how we are looking at using this. Okay. So going back to this figure, we're going to start with only looking at this scaffold. So this is our scaffold I talked about that is a polymer solution that we ended up freezing. So it has these large pores throughout it. It's actually very spongy in nature. Because it's spongy, it can take a lot of loading, right? And so with that, what tissue might we want to use that for? I already mentioned that bone, right, has to be very strong and sturdy and take a lot of loading. So that's what we're going to focus on first for this. So we have done a lot of work focused on scaffolds for bone regeneration. That's kind of where I come from. That's where we really started when I started my lab here at Dartmouth. And so there's different ways for us to combine scaffolds to make them more appropriate for bone. So for instance, this is our cryogel structure I just mentioned that's kind of spongy, and it's really useful for bone. The cells really like it. They will put down new bone matrix. And I mentioned it's durable. It is durable to take loading, but it really isn't the strongest, right? Compared to 3D printing plastic, for instance, it's not that strong. And so what we can do is we can actually combine it with 3D printing. And you can see this picture here. We have 3D printing throughout this polymer matrix. And so what that allows us to do is keep the really positive properties of the cryogel scaffold that the cells really like, and mix them with the mechanics in the 3D printing to really provide a support structure for bone. What's really cool about this is because we're using 3D printing as kind of the framework that our scaffold will be made inside of, we can actually use this in a very clinically directed way. Okay, so very commonly, if someone has any sort of craniofacial defect, whether it's from a car accident, they have a tumor in their jaw that they have to have reconstructed, a birth defect, etc. What you do is you go into the hospital and you get a CT scan. The CT scan is going to provide a three-dimensional image of that structure. And then the surgeons already do this. They go in and they kind of plan how we're going to move everything around to help basically put the bone where it needs to be and get the face looking like it should and did previously. And so what's cool is that we have those CT scans. So we can actually take them and basically create our scaffold in the exact shape that we want them to be to fit that defect site. So we're able to make very patient-specific structures that are then patients actually going to fit the bone that you would be placing in. So that's what you're seeing here. So this is the lower part of your jaw. This is an example of an area of the bone that had to be removed because of a tumor. Typically what they do for this is they actually move bone from another part of your body, but instead we can actually take this and create a little mold and make our scaffold to fit into this shape. So it allows us to make something that's patient specific, that's combining different types of tissue engineering that the cells really like, to basically create something that ideally is improved in treating and is much less invasive than having to take bone from a donor or another part of your body to fill that space. Okay. So that's one way we use this. Another way we can use this is pivoting more towards the interface of tissues. So I mentioned, bone, done a lot of bone. We started getting really interested in kind of the tendon and bone interface. The tendon and bone interface is so commonly damaged in athletes, in young people, as well as shoulder injuries as people age. Very, very common injury. And so what we started doing is we started trying to figure out, okay, if we want to replicate the bone and the tendon, what scaffolds make sense for that? So I already mentioned 3D printing. I already mentioned these cryogels, these frozen scaffolds. They're great for bone. So if we look at the bone tendon interface, which is a little bit cut off, but the bone is right here, and then your tendon comes right off of it right here. And so if we look at this, there's all these different zones. We have our zone of bone right here, but then as we move into the tendon, it becomes very aligned and very fibrous. Okay, so with that in mind, we wanted something instead of very three-dimensional and spongy, we wanted something very fibrous and aligned. And so there's another technique that I'm not going to go into, and I'm happy to talk about it later if anyone has questions, but it's called electrospinning. But it lets us make these very fibrous scaffolds. So that's what you're seeing here, which looks just kind of like a white blob. But if we zoom in on it, you can actually see we have these fibrous structures. And then as we move into what I would call the bone side of things, we have these more porous structures. So it allows us to, again, combine different types of scaffolding to imitate different types of tissues and what they look like naturally. And so this has been worked on by a PhD student in my lab, Ritha, who's pictured here with some her undergrads have been working with her. And they've done a lot of work on replicating this interface and trying to understand the mechanics behind it. This is something that they could use to either understand different treatments that people are trying or to actually implant it as an alternative. Okay, so again, we talked about actually replacing tissues. Another project we've been working on, I just want to show you kind of the range of tissue engineering, I think it's really interesting. Another project we've been working on is actually supporting implants. So a lot of times folks, will have an implant, whether it's from a bone injury or they have some sort of cancer, etc. What I want to talk about today very briefly is using this with amputees. So in amputations, which are very, very common for a lot of reasons, especially in our military, after service, what will happen is you have a leg amputation, and then the general, the standard of care for this is they get a socket that goes basically under the amputated leg, and then the prosthetic is attached to the bottom of that, and that's the standard of care. The issue with this, which you probably would never know from unless you have one of these because you can't see it, but the femur that is in the soft tissue, when it ends at the end of the amputated limb, is no longer connected to this prosthetic. So what happens is there's no good force distribution. So really it's very, very uncomfortable. I think only like 75% of people, or 75% of people actually stop using their prosthetic because there's not great force distribution. It's very uncomfortable. So these amazing surgeons have come with this procedure. It's called osseointegration. Osseo means bone, integration means with the bone. And so looking at what they do is they stick a metal rod into your femur, and then it sticks out of your leg, and it directly connects the prosthetic. So it's a better force distribution. It's way more comfortable. And these people can do amazing things with this. They can go and surf and run and swim and do amazing things. So it's a great procedure. It works really well. The issue is that what happens, you have this metal rod sticking out of your leg. There is no adhesion between the skin and the metal. Skin does not stick to metal really well. And so you have this protrusion of metal out of the leg, but the skin is very loose around that. So it's very, very at risk for infection. And so that's the downside of this procedure is there's been not a very good way to actually adhere this to the metal. And so another PhD student, Adelaide, has been basically trying to tissue engineer a structure that goes under the skin that better adheres the skin to the structure such that you don't have any loosening around the implant. And the reason I have this picture of a horn up here, which is what she likes to stick on there, but when we were trying to figure out how to do this, we really went back to kind of nature and thinking about what in nature, in our bodies, do we have bone penetrating skin like this in osseointegration, right? When do we have this naturally? So in people, the only time you have this is actually the fingernails, right? When you look at your fingernail, it actually does go into your skin and you have this interface where you have it protruding from your skin. Another great example are in horns. So in horns, you actually have this bone that's protruding from the skin as well. And so that's been really kind of a driving force for this project. We're trying to understand what is happening at a molecular level, your fingernails and horns, that we can add to our scaffolds to increase this adhesion. So another way we're helping to basically improve, tissue growth, instead of really replacing a tissue here, we're just supporting an existing technology that's very, very awesome. It's changed a lot of lives. Okay, the last one I'm going to go into changes to Manuka honey, which we did get a slight teaser from earlier. So one of the big driving forces behind using Manuka honey is that there is a huge issue with antibiotic resistance. This has become a growing issue in society. So finding alternatives to this is really important. Manuka honey is a honey that is from New Zealand. It's been used for centuries, since the Egyptians, for medicine. It has really good properties for antibacterial, kind of reducing infections, etc. So people take it for gut health, people use it for potential infections, etc. What happens is the honey, when it breaks down, there's kind of a couple different parts of it. And one of this is the methylglyoxal. Your methylglyoxal is really antibacterial. And so we started putting this in our scaffolds to say, okay, if we can harness that antibacterial component of honey, because honey is, of course, very sticky and wet, where you don't want to just stick it in a wound, you want it to be delivered in some way. We've tried putting it in different types of scaffolds, and you can see here in this picture that we have, this is basically just a infill of E. coli bacteria. And we have this breakdown and clearance that you can see with these arrows here around our scaffold over time, where the honey is being released and shown that it can clear bacteria. And so the idea behind this is not that it's replacing antibiotics, potentially could be used to augment or support antibiotics to have this improved healing without being able to use less or different antibiotics as well. And so that's one of the ways we've been using this also in infection, but this could be used in a number of the scaffolds in a number of scenarios, right? So when you have trauma, you have a car accident, you're gonna have a lot of debris in a wound site, so there's a really high risk of infection. So having honey and something like that with our scaffolds would be really beneficial, even if there's not an infection there yet, to prevent that from happening. So to bring us kind of back, again, our group is focusing on all these different types of scaffolds and really pivoting them toward, growing new healthy tissue or helping to support tissue around an existing biomedical technology, whether that's implants, etc. And so I do want to kind of talk a little bit about where this is going. So that's kind of the end of our spiel of what we've been working on for the past 3+ years at Dartmouth. But what's really cool about tissue engineering is it's kind of broadened out from just looking at medicine. Okay, so I have given you a lot of examples of using tissue engineering specifically for, treating different types of diseases and injuries. But tissue engineering has also expanded to using engineered meat. So trying to find alternatives, for instance, to help with the environmental changes that we're having, right? So to think of ways to engineer meat and provide alternatives for that as well. Also engineering leather, so trying to reduce the use of real leather. And I already mentioned other types of tissue healing things. So organ on a chip is one of those as well, which I'm happy to talk about more. But there's just a lot of really cool opportunities within tissue engineering that has expanded from this initial focus of just healing different types of wounds. And this is slightly cut off, but we can see this whole graph. What you can see too is at the kind of the beginning of tissue engineering versus over the years. There's been so many publications and companies that have started to do this, which is really amazing. So tissue engineering is a little bit tricky, right? It's a new field. It's different than just an implant or something like that. So it took the FDA a little bit of a while to figure out how to process new types of tissue engineering devices and things. But since this has happened, there are over 20 to 30 companies that are currently using tissue engineering in the market for clinical use. A lot of them do focus on infection reduction and things like that. So for instance, I have a colleague who has a device that he uses in the gum. And so after you have a tooth pull to prevent and help that healing but prevent infection, because your mouth is really high risk of infection because you're eating and drinking and talking and things like that. So tissue engineering is already being used in clinics, which is very, very cool as well. And I'm happy to talk about that some more too. And so I know this is really focused on ethics. And so I do want to touch on why or how we think about ethics when we think about tissue engineering and in biomedical engineering in general. So I teach an introduction to biomedical engineering. It's an introductory engineering course that's really around sophomore level or so. These folks really go back to this a lot. And it's great to see because a lot of times we're teaching technology and they have constant questions on like, well, how do you explain that to a patient and how do you go about, developing this in a way that is ethical, which I think is great that we're already thinking of this. And so in BME in general, we really consider safety, disease burden, cost versus benefit a lot, right? So considering how to find the best practices to get to an outcome while doing it ethically. So in the class I teach, we also talk a lot about how to talk to patients and how to kind of bridge that gap, being able to explain something in a way that's understandable to people in the general public and educating folks so that also can make really decisions for themselves within these types of situations. And so I think it's important, in adhering to this really fosters that trust, that integrity, and that responsible innovation in the field. I think it's something important to touch on as well. And so I did this really quickly just because I wanted to do more so towards tissue engineering, but in tissue engineering itself, there are a lot of potential, I think, or a lot of aspects that should be considered on the ethics sides of things. So for instance, when we're looking at, this is talking about bioprinting systems, I just found this earlier today, I really liked this graphic, but when we are giving you a scaffold that has cells in them, right? Knowing where those cells come from, are they from a donor? Are they your own cells? Thinking about the source of those cells, and that's a very, very important aspect of this. Another is ownership of printed tissue. So if we are taking someone's cells that were donated and then printing a 3D printed tissue, thinking about that tissue's ownership and compensation as well, I think is really important. Thinking about a lot of cultural and religious aspects is really important. Something you have to think about a lot as we're developing these technologies as well. And so I just think those are all important things to think about. And so considering all of that, I think there's a lot of really, really great steps listed kind of here, which again, this is smaller, I'm sorry, but thinking about safety and using sustainable materials and achieving this kind of technological equity is really important. So these are all things that I know a lot of my colleagues are considering as they are developing new technologies, using materials that are accessible, using materials that can be recycled or that break down, into products that potentially don't create waste. All of those I think are really important aspects as well in this field and something that needs to be continued to look at. And so with that, this is my lovely lab. They do all of the work. I, at this point in my career, just kind of chat with them about what they're excited about. And so they've done an amazing job on this work that I've shown you today. This is kind of just a teaser of a lot of the work we're doing. But with that, I would love to take questions and have a conversation about this. Thank you.
Currently, is this implemented in Dartmouth or around the state since it's so kind of
Do you actually people? Yeah, so in Dartmouth specifically, they have some types of structure. So a lot of stuff this stuff putting in big defects is a newer technology that's still kind of moving through the FDA. But thinking about, like I mentioned, some of the smaller constructs that have antibacterial additives and things, that's very commonly being integrated into technology here in New Hampshire and across the country as well. So to answer your question, it's definitely building. It's definitely still very new, but it's something that's really building up.
So in New Hampshire, is it only at Dartmouth right now?
Sure. I don't think right now.
And you mentioned Manuka honey, so where does that come into play?
So Manuka honey is, it's from New Zealand. It's something that a lot of wound clinics will actually look at. So a lot of wound clinics will take patients that have a really difficult time, with wound care, that have an extended injury or something that's just having a really difficult time treating. And so that's a lot of times where things like Manuka honey are implemented, right? Because that's kind of, it's not the normal medicine, but it's something that I think is
at the top, right?
Yeah, and yeah, it's something to talk about. Yes. And it's actually used in for ulcers as well. That's very common use. Yes.
Is Dean Kanan doing much of the same thing that you're doing at Dartmouth, or are you guys in two different areas?
Two different areas. but I know.
I'm sure you do.
That was great. No, two different areas, but there's a lot of overlap. I think that's one of the best things I think about Dartmouth is there is a lot of overlap between all of the faculty and all of the clinicians. So different things, but related in a good way. Yes.
Done a good job explaining something very complicated, so something that I need to clarify, the scaffolding.
Yes.
You're filling in with some things are natural, some things are synthetic. So natural, are you filling some things that's there's a burn? You want to fill in skin. Are you using some live skin of people?
No, so the scaffold takes the place of grafting. So, you know, skin grafts work, but they're not very aesthetically pleasing, and sometimes they're rejected and they're uncomfortable and they don't heal really well. And so this would actually take the place of it. So what this would do instead is it provides a three-dimensional structure that's similar to the graft, but it has, you know, other benefits, like you can add in, you know, the patient's own cells from somewhere on their body, or, you know, with burn victims, there's a lot of scarring. And so you can put something in there to hopefully mitigate scarring as you're having that healing around it. So it's essentially just replacing entirely the graft. It's providing that entire three-dimensional structure. So it's basically, when we think about tissues are composed of, at their core, extracellular matrix. It's basically this three-dimensional structure of all these different fibers that make up that three-dimensional structure of the tissue. So the scaffold is really providing that. It's providing the three-dimensional structure that the tissue is composed of. And so that's why we have to consider which tissue we're looking at, because as you mentioned with skin, right, that three-dimensional structure looks very different than if we were doing, you know, like a vessel in your body, like looking at, you know, your aorta, for instance, right? Those tissues look super different, so they need different types of scaffolding.
Okay, so I had just asked about skin, but if you move to something else, can somebody donate, donate organs?
Mhm.
Can you donate tissues to have available for you to use for blood vessels on something?
Yeah, so that would be more for organ donation, but yes, so one of the reasons tissue engineering is really picked up is because there's a huge shortage with organ donations, right? So organ donations, there's organ donations are amazing and they save so many lives, but there are concerns, always concerned with matching donations, you know, having that, you know, the immune system not reject that, which sometimes it's even years later that even happens, and there's all these complications, but even at its core, there's a huge shortage. And so ideally this would replace that. Now, we have done work, so for instance, I didn't talk about this, but we have some skin work we're doing where we're currently taking biopsies from a dermatology department at Dartmouth, where that's just discarded tissue. It would get thrown out from various procedures. And we are taking those cells and growing them on the scaffold to see if we can retain the coloring from people's skin to basically try to get a better match than using these grafts. For instance, that would be an example of taking patient tissue and using it. I would say that's more of a patient specific thing, but like if you were to take like a vessel from somewhere and just implant, they do that anyways. That's always already kind of like one of the big pipelines. There's just a shortage of that kind of tissue.
You notice on your slides out there, you have pancreas. Might that get focus of some who may suffer pancreatic cancer in the future that may replace that function for it?
Yeah, so I didn't go through all the different types of scaffolding, but one of the types of scaffolding that's really big right now is bioprinting. And bioprinting is 3D printing, but it's 3D printing with cells and materials in a very sterile environment, so that you can actually make a full tissue. So people are trying to bioprint bladders and livers and pancreas. And so, yeah, exactly. The idea is if successful, you'd be able to create this full organ for a person that you could implant. So that would totally mitigate the whole, you know, any of the concerns behind donors and things like that as well. So yes, that is something that's within the last 5 years really taken off. So it has a ways to go, especially because thinking about organs, they're very complicated, right? There's a lot of different types of tissues and cells. So that's where it's headed. I think that's the goal long term, is to be able to print something that's specific for the patient. Which you're right, that if someone had a disease state or something like that, then you could just replace it versus having to create for a donor. Yeah.
I think you got some very overview to the research work that you're doing in scaffold generation. And linking it to ethics, can you talk about where the industry is today with the use of stem cells? Historically, there's been a lot of concern about embryonic stem cells, and where is the industry today with respect to stem cells?
Yeah, so stem cells. So stem cells are, your whole body is filled with stem cells. All of us have stem cells. There's different types of stem cells. So we have tissue specific adult stem cells. So those are stem cells that are in your existing tissue that are basically waiting until your tissue needs them, you know, if they're injured or they're, you know, aging and things like that. Embryonic stem cells are of course taken from the embryo, so that has a lot of ethical concerns. And so as it stands with that kind of research, it's very restricted at this point. The reason people wanted to use embryonic stem cells is because they're the only type of stem cell that actually can become any type of tissue in your body. And so what people started to do is they did induce pluripotent stem cells. And so what that is they started manufacturing cells that they were able to reprogram to imitate embryonic stem cells to replace their use. So I think, you know, on the ethics side of things, stem cells themselves are wonderful because they can become different types of tissue. They're this really great resource for regeneration and healing. I think that science itself has tried to really kind of bypass some of the concerns by making their own types, which I think is a really great alternative to using things like embryonic stem cells, which just has so many ethical, you know, issues and connotations behind it as well. And so, yeah, those that's one option, but we all have stem cells in our body too. So I think utilizing those, there's not quite as much ethical concern behind that more recently, just as more is being understood about those stem cells as well. Good question. Yes.
The color matching study that you're doing with skin biopsies, that seems pretty cool. Thinking through some of the forms that I filled out or the digital pad I has to sign without actually seeing the form when I'm at a hospital, you know, as sort of thinking about people sense here,
Yes.
people who are, you know, going in for a biopsy for some other reason. And there's a little checkbox somewhere down in there that says, hey, we might do some stuff with this in school.
Yeah.
How does that?
No, it's such a good question. Yeah, it's such a good question. So really, I will say, so every work that anyone does in the country with anything human related, so human cells, human tissue, has to go through a processing, first of all, through the IRB. The IRB is the Institution Review Board, and so they go through and basically help either say this is not ever going to happen, or this is something that we need to rework so that it's appropriate. And part of their reworking is also making sure that the information is presented in a way that is actually equitable and understandable, and discussed with the patient. That's part of the procedures that you have to go through if it has IRB, or requires IRB approval. And so to answer your question on that end of things as well, that pipeline also is very much with the doctors and making sure it's communicated in a way that the patients understand. And on our end, you know, all of the tissue that we work with, you know, has been again taken, but reused because it would be normally thrown away in the patient's center. But yes, 100% on your end, I will say with the cells, so let me go back. So with the HeLa cells, right, HeLa cells were taken and then used behind someone's back and immortalized. And so then the cell line was existing forever. Patient's family didn't know, there was all this genetic information that came out, et cetera. So that's the IRB's responsibility to make sure that people aren't keeping the cells forever. Any cells that we use last for, you know, a few weeks and then they don't last anymore. So I think that's part of the IRB reviews to see if that's potentially an issue with how we're working on things. You need to get your things renewed, so you can check in again. And so there's a lot of checks and balances. It's not perfect, but I think it's definitely improved over the years to hopefully streamline that and improve it. Because I think it's really important. Yes.
Is there anything going on in China where we might be less worried about some of the ethics that would be? Yeah, in China, are they like proceeding at a faster rate? Is there research coming in there that's shared?
Yeah, so I have no idea, generally speaking, but one of the great things with science is that the way that you get recognition for any work that you do is you publish it, right? And so publication is the best way to provide that information to other people and share that knowledge. And then you're able to use anyone's techniques or information, you know, because it's been published. And so I would say that, you know, everyone is sharing everything. So I don't think there's really any sort of unfair advantage or race. Now, I will say, you know, that's across the whole world. There's different regulations. So for instance, our FDA here is very, very strict and very different than even the one in Europe, right? So there's always differences in that. If there just will be unless we decide worldwide that we're gonna have the same regulations across the board. But science-wise, I think it's become this very collaborative community, which is great. So, you know, I don't think it's any sort of race in that aspect of things.
Countries that are light year ahead of us because they're able to do certain things that would be restricted in other countries.
Yeah.
If that happens, they would share everything.
Yeah, well, I mean, there's not really anything in tissue engineering that's currently restricted either. I think everything's been, you know, there's nothing that the people want to do that they can't do in tissue engineering at this point in time. I think the biggest restriction has really been potentially types of stem cells, but again, the research community has found a way to kind of get past that and be able to reprogram other cells to do the same. So I think when there are kind of those hurdles like that, they're able to find ways to move as a community around them.
Here's something that's, for property aspects of engineering, because, you know, in sweet car, they have to, you know, links to the scaffolds, right? Because
Yeah.
you can't really have, basically, like, human organs Excel, so that's the, you know, what I mean. All some of the aspects.
Yeah, so you're right, it's 100% focused on the scaffold design, so the combination of the materials, the way that you're making it. Typically, if you do something unique, you file IP early, and then you kind of end up seeing if it's something to pursue long-term or not. But yeah, you're 100% right, that's really the aspect of tissue engineering that is patented. And we have this intellectual property is the scaffold portion itself, it's not the cells or anything like that, that's not really the technology, we're just basically, you know, using them to help support it long term. It's a good question. Yeah.
You guys, there is stuff on the market, you said 20 or 30, there was the, addendum plan for, is there anything else cool, like, what's those?
Yeah, there's some cool bone stuff, there's some cool skin stuff, so, the ones that have moved forward, and I don't want to discredit it, because we mostly do bone, but bone is one of the simpler tissues in your body, it heals quite well typically, so for instance, when you fracture your, you know, when you're young and you fracture your wrist, right, if you set it, as long as there's nothing else kind of crazy happening, it heals really, really well. So bone is the only tissue in your body that heals without a scar. And so it's one of the easier tissues to treat, compared to something much more complicated like your pancreas or your, you know, or your kidney, for instance. And so that being said, a lot of the technology that's on the market right now in tissue engineering that's made its way through the FDA into patients is focused on the more simple tissues, so skin and bone, and things like that. That's kind of the primary landscape, but I mean, people are moving forward a lot. Now, it's one of the funny things is that when tissue engineering first, in the last, you know, probably once it was 10 years or so, everyone started making these very complicated tissue engineered structures, right? These really cool, like reprogrammed cells and the tissues, we're doing all these crazy things. You know, the best way to get something through the FDA into patients is making it very simple. Right, making it something that doesn't have any cells, it has no bioactive factors, and it's just a material, right? So those are the ones that have really moved forward, are the ones that are simple and really focused on healing and not being super fancy. Not that there's anything wrong with the really fancy ones, but those are the ones that are practically moving forward because they're usable, they're ones that you can actually store long-term, et cetera.
Is there anything being done in the area of treating issues in the eye, such as the optic nerve?
Yes, so I don't have a good background on that, but there is tissue engineering being done, especially with the cornea. Optic nerve, I would assume so. I have to do some more research, but yes, folks are looking a lot on glaucoma and different types of things. So interestingly, I've mentioned hydrogels and these kind of jello-like structures, scaffolds. contact lenses are actually hydrogels. So that was already, of course, that's not replacing anything in your eye, but that's a good pivoting point of thinking about scaffolding, something that could potentially be tuned in. So yes, there's a lot of work being done in the eye also. Good question. Yes.
Thank you for your thought. I think this is fascinating, and I can't help but think I'm not a biologist and you're a biologist here. I can't help but think this is the new frontier of the next century. All these advances in biology, genetic engineering, tissue manufacturing. If you're in the industry, project 20, 30, 50 years from now, where will you be in tissue engineering? But do you see any challenges or risks or things you should be considering? In getting there?
That's a hard question. Yeah, no pressure.
Let's start with the first question. Where do you see?
Sure. Okay, so I think that it's gonna be much more readily available. I think tissue engineering, it's been a while now. It's been over, 30 years, but that again, comparatively to other fields, is still really new. So the fact that it's starting to get into the market now and being used in clinics, I think is really important. And I think it's really headed in that direction of being integrated more regularly, which I think is really exciting because I think it provides a lot of opportunities, again, to kind of bypass the complications that come with organ donation and potential rejection and grafting and all of those other things. So I think it's much more readily available, especially the ones that aren't quite as complicated. But bioprinting has come a long way. Bioprinting is the printing of organs or tissues. So that's something that I think also will be greatly probably improved. I'm not sure if we'll be printing full organs that are fully functional, but I think we're already headed in that direction, which is very cool. My group doesn't really do that. But it's a really, really interesting field. Yeah.
So it's hard for me to see a downside to this. Given the things that you said that addresses, it contributes to human well-being, flourishing, healthy bodies, avoids equity issues by making something available for many people, whereas right now, organ transplant market is very software guide. And so it's hard for me to see the downside of this technology. I can imagine some religious objections, natural, maybe some cultural objections because it's taking in some sense, but from an ethics perspective, it seems to me a win-win on all sides. You might be concerned about making this accessible to all people, maybe the cost of technology is prohibitive, I'm just, as an ethicist or a philosopher, I'm looking for possible ethical objections to this. I honestly have a hard time finding.
I'm glad I sold it to
And
you.
you're informing the patients of what's happening to them, in their bodies, and educating there's a question of equity of access to this technology. I think there's responsible innovation, sense of risk to people, you don't want to endanger people.
Yeah.
But aside from some of those things, I think it's an incredible advancement.
Yeah, and that's why I think the group as a whole, that anyone that does streaming feels that way. And, the accessibility thing is, I think, something that we're always concerned about. On the side of that, it's just, I always remember when 3D printing was first introduced and now, kids can buy 3D printers off the internet for like $100, right? And do it in their house. And obviously they're not making intricate organs, but I just think that as technology is developing these fields, there is stuff being done to keep it accessible. So I think that's kind of the biggest thing to keep our eyes on moving forward. This is keeping it that way. So I think it's really important. But I agree with you. I think there's also just many pros to it, and it's a very creative field, which is really fun. You get so many different types of minds in it. Tissue engineering and biomedical engineering, it combines engineers, that combines biologists and chemists and mechanics and clinicians and policymakers, and it's just a really great, I think, infrastructure for success with it.
Brain, are they able to reproduce parts of the brain?
They are working on that. So the brain's, of course, very complicated, right? So there are parts of the brain that they are trying to regenerate. A lot of it is more so on the side of re-innervating parts of the brain and getting those neural networks back up versus fully replacing the tissue. A lot of work is looked on, especially not even just brain, but peripheral nerves don't feel really well once you damage a nerve a certain distance away, it will not heal. So there's a lot of work looking at those kind of synapses and trying to regenerate that specifically. The heart's also really hard, you know, the heart tissue, when it's damaged, it becomes very scarred. And there's just difficulty with regenerating it. So a lot of it's trying to take the tissue and kind of backtrack it to a healthier state, or, you know, having a way to bypass that on kind of the electrical side of things. So it's similar, those are two other really complicated things. Yeah, I don't do anything. But yes, there definitely is work being done on it.
It's huge problem. So many.
Yeah.
That kind of falls into that, which is saying it's a.
Yeah.
Diabetics.
Yes, 100%.
Hard to do.
Yeah, it's hard. Neural injury is tough, you know, but there's a lot of really cool tissue engineering work that if you're interested, I would encourage you to look into, but we don't do anything with that, but there's a lot of work on it. You know, there's conferences that are only tissue engineering conferences, they host every year, and there's so many people doing it. They can, you know, literally split it by tissue type, right? They'll have the neural side of things, the bulk side of things, cardiovascular side of things, so.
So thinking about like the ethics of tissue engineering and everything, that one of the places where things get more complicated is when you start talking about like using donor cells or genetically engineering someone's own cells to do what you. So I'm just thinking about like where's the divide from where you can like put in a scaffold and have the patient's own cells fill it in versus where you might need donor cells or you might need to do genetic engineering. Yeah, I'm just kind of curious, like what's the different injury types or different biological?
No, it's a really good question. So it really depends on the disease state of the tissue, right? So there are certain types of diseases where a whole organ, all of the tissue is affected. Whereas, for instance, if you had to have a bone tumor removed, that part is damaged, but the bone around it is healthy. Right, so that's those situations we're able to utilize healthy surrounding tissue. That's when we're able to put in, we call it acellular, but a no cell scaffold. That's hopefully just going to encourage the healthy cells around to migrate into it. So when you're not able to do that, it's either because something is just too damaged, there's not enough there to harness that, or if there's a disease state where you just have to completely get rid of that tissue completely, you know, entirely, and then you're gonna have to get those cells from somewhere else, basically. But I agree, I think, so even on an approval side of things with like the FDA, right, they will move something that has no cells through so much faster than something that's requiring their own cells. And so I think there is technology already where a lot of people are taking people's cells out of their body and spinning them down and taking out and putting them back in, right? So I think that bridge is already currently being crossed. The donor one's a little bit trickier, but we do donor organs, you know, so I think there's that also. Yeah.
So I did think about a possible problem.
Okay.
You save people's lives. Could you ever see this technology being used to design better, make ourselves better, to redesign organs, to improve ourselves? I can see that it could become a little bit problematic.
Yeah,
Because now, I don't want to say playing God, but we're starting to race to create a superhuman.
yeah, like designer,
Yes.
yeah,
Designer.
yeah. Mhm. Yeah, so, I mean, maybe, I think the potential, but potentially, I think, you know, a lot of times what this is targeting is a tissue that's either so injured that it's just not even usable. You know, I guess you could see someone wanting to replace their heart, for instance, when they're getting much older with a heart, I can see something like that, so. Yeah, I mean, maybe, that could definitely be a concern.
But we're far away from that.
We're far away from that right now. Yeah, I think first we have to get the hearts to work and then we can consider who should be getting them. Yes, yes.
I want to be respectful of Dr. Hixon's time. Maybe we have time for one more question.
Yeah.
I just wanted to, I was very interested in you said in the fund. My father was aging, he was 94, allergic, becoming allergic to all antibiotics. And he developed this. He had a cyst-like growth that he scraped and got infected and had a major autonomy. And because he was, I had 3 surgeons tell me that they wanted him to go home, but they didn't know if it would ever heal. And I was able to heal it over the course of a year, filled in with new. And I know we're talking about technology, but because he was becoming allergic to everything, I had to look into old methods, antibiotics, other areas of his body that breaking down, like athlete's foot. And I learned just, you might be interested in it, that this old time stain gentian fiber has antibiotic problems. Weirdo. He had purple feet for a while, but they're not second. And another one was Hawaiian silver. So sometimes I was interested because you mentioned that. And I mean, sometimes you can mix and
Yeah.
come up with, because our antibiotics are certainly modern day, but they created a monster. So,
Yeah, no, I think, I think it's important, like you said, to kind of go back and think about what's been used forever and what's worked really well. And think, when somebody's been used, like I said, for centuries, since Egyptian proteins really for gut health. And yeah, I think it's a great way to improve things and to keep things accessible.
I want to thank Dr. Hixon again for joining.